Here we are at the very first Cell Coast conference sponsored by Moffitt here in Tampa, Florida. And I'm here with one of our outside guests, Dr. Krina Patel, friend of the Coast, who's really an expert in multiple myeloma. So thank you for being with us here today.
Thank you for the invitation.
So speaking about multiple myeloma, you spoke about how a lot of your patients really enjoy the treatment-free interval they get after CAR T-cell therapy. Maybe you can give us a little bit more information about that, what your experience is.
Yeah, I think CAR T has really revolutionized heme malignancies, but myeloma, specifically what we learned, is not only are patients getting amazing response rates, right, 98% even in relapse refractory, we're getting a PFS of 3 years, which is phenomenal as a one and done, but that one and done, what it really gives our patients is this time away from having to come in for injections, steroids, infusions, that even those therapies are great, it does take a toll on our patients. It costs money. They have to take time away from their families, which is what they want to be with, and they get to go away. And they come once a month or every 3 months even sometimes just to check their myeloma labs. So we have big phase 3 studies that have been done, CARTITUDE-4 and KarMMa-3, that actually looked at PROs and for patients who are getting standard therapies that require the weekly or every 3-week treatments versus CAR T. And what they've showed is in every aspect of what patients find important, CAR T beat, in terms of quality of life compared to our standard of care options. And so in real life, when I have patients that get CAR T and they're doing really well, as they relapse, unfortunately these are not curative yet for myeloma, even though we get great long-term PFS, when they relapse, they ask me, can I get another CAR T? And that's so powerful, right? Because that really tells me these patients really do enjoy that life that they get outside, and they're not as fatigued. They actually feel back to normal, some people say. So I think really we need to do better for our patients just for that reason.
Yeah, I think this concept of time toxicity has really come into play. And CAR T-cell therapy, I tell my patients, takes an investment up front of time, but then they get a lot more time away from the hospital sort of on the back end, which is really wonderful. I wanted to ask you about patients who relapse after CAR T-cell therapies. What are some of the exciting cellular therapies or non-cellular therapies that you see in myeloma for that patient population?
Yeah, I think we have so much going on, which is great. But I really do think that more CAR Ts, we'll see if that's feasible for everybody or not, especially with lymphodepletion, et cetera, especially in relapse refractory patients, but really new targets. So, we have BCMA CAR Ts right now, standard of care. We're excited about GPRC5D. We have a bispecific, talquetamab, but we also have CAR Ts. We also have CELMoDs that are in the works. They're not quite approved yet, but trials that are using CELMoDs after CAR T that show some great responses. And of course, we have our regular chemotherapies if we need them too, for patients maybe that aren't responding, their T cells aren't working anymore. We need better ways to figure that out, I think, for our patients so that we can decide on the right therapy next. We have so many options, but again, really exciting to say, how do we combine CAR T, or how do we debulk with bispecifics, et cetera, that I think is hopefully in the next couple of years we'll have a lot more data for that.
Great, well thank you very much for sharing your expertise and look forward to hearing from you next year maybe.